Good evening, and thank you for joining us tonight. This webinar is the last segment of the TSRA and Atricure webinar series titled The Origin and Current Practices of the Heart Team. It is our pleasure to join you tonight for what will be a lively, engaging, and timely discussion. First, I would like to extend our heartfelt thanks to Atricure for this grant that made tonight's session possible. And second, I would like to introduce your moderators for tonight, starting with myself. I'm Chi Do Nguyen, and I'm a current PGY3 I6 CT surgery resident at University of Michigan, and I'm also the current TSRA Education Committee Chair for this upcoming year. And joining me is Dr. Harji.
Hi, everyone. I'm Samir Hirji. I'm one of the cardiac surgery fellows at the Brigham. I was in the 4+3 program, so I'm in my second year of my 4+3. I'm also currently the second year treasurer for the TSRA. So I would like to extend my warm welcome to everyone, all the panelists, and everyone who's here tonight. So at first, I'll start with introductions. So I have Dr. Michael Mack. He's very familiar. Everyone's very familiar with Dr. Mack. So he's the chair of the cardiovascular service line at Baylor Scott and White Health in Dallas. He's a co-principal investigator of the partner trial of TAVR versus surgery, and also has been the former president of the STS. So we are very happy to have Dr. Mack here. We also have Dr. De La Cruz, who unfortunately is unable to attend. He's the chief of aortic surgery at the Brigham Women's Hospital, and he's currently in the operating room. So he extends his regrets for not being able to make it.
And I have the honor of introducing our final two panelists for tonight's discussion. So Dr. Isaac George joins us from Columbia University Medical Center, where he serves as the surgical director of the Structural Heart and Valve Center. He is also one of the few physicians in the world that is trained in both cardiac surgery and interventional cardiology. And then also Dr. Sarah Pereira joins us from the University of Utah, where she serves as the surgical director of the structural heart program there and is also program director of both the integrated and traditional thoracic surgery programs. So thank you to all the panelists for joining us today. Before we turn our attention to the panelists, I would like to give a little bit of background on the heart team and what we were going to discuss for tonight's panel. So multidisciplinary teams are driven by a need to bring together multiple specialists for an individualized treatment plan. And in CV medicine specifically, we've used this first in trials comparing myocardial revascularization and then subsequent studies evaluating TAVR. So official clinical endorsement was later issued in 2014 by the European Society of Cardiology and Cardiothoracic Surgery, and that put forth a class 1C recommendation to use the multidisciplinary heart approach. So over the last decade, this has expanded to a variety of CV disciplines, but since this approach has been more extensively used with the heart valve teams, that will be our focus tonight. And our hope is that this discussion will lend to future ones in the different subspecialties of CV disease. So without further ado, I'll let Samir take the lead with some questions.
Sure. So the first question I have for the panel, especially for people not familiar with the heart team, is who makes up the multidisciplinary heart team at your institution, and what are their corresponding roles? Do you feel like there is quite diversity in the team that makes up the heart team? And if so, how so? Maybe Dr. George first.
Yeah, sure. So, the heart team, I think, just to first of all give credit where credit is due, I think, the folks who are really in the trenches of TAVR early on, and I think Dr. Mack is obviously one of the key leaders in this, really did a good thing. I think this was probably at the time, at the height of the cabbage PCI wars, and I think the reaction to that was to say, how can we do this better? And maybe it wasn't. Maybe it was just totally unintentional, and the FDA forced them to do this. But someone did a good job of saying, look, let's make sure that we have parties who are interested and involved in the care of patients with aortic stenosis, and create a model where all of these patients get evaluated and treated jointly. And so with that, I think the early TAVR trials really set a precedent for ensuring a level of knowledge, a level of quality, a level of equality, let's say, and parity among all of these centers. So you have people that all have a stake in the game, that join together. That includes, a lot more people than you would think. Originally, just from, let's say, a paper of TAVR, you would think that everyone needs to be seen by a surgeon and a cardiologist, and that's it. But it's really evolved into so many more people. That includes the key advances in outside of technology for TAVR has really been in imaging. So our imagers, whether it's CT or echo, have been critical. We have our coordinators, and those are people that screen for trials. We have our NPs, PAs that are on the ground, kind of really doing a lot of the legwork, seeing the patients, doing a lot of the clinical follow-up. We have our general cardiologists. We have our actual teams who are taking care of patients as trainees, anesthesia, cardiac anesthesia. And again, all of those people really are people at the table when we have our structural heart team meetings. So I think those are our key people.
So of course, like there's substantial variation in what comprises of a heart team at multiple institutions. So Dr. Pereira, like how was it easy to adopt towards a heart team approach at your institution from your experience then? And sort of what some of the positive things that you've experienced or gained from that, as far as patient care or outcomes, if there's any anecdotes?
Yeah, thanks. Thanks for having me on the panel. It I don't deserve to be here next to these icons of Mac and George. So I would say that at Utah, we have a fairly small heart team. If you were to compare us to a Columbia or New York or Texas, but I think in the academic environment, what is the nicest about having an academic team is just collaboration with your colleagues. And so just the collaboration between the interventional cardiologists and the surgeons. We have 6 physicians on our heart team, so 3 interventional cardiologists, 3 surgeons. That doesn't include our structural cardiologists, imagers, and other coordinators. But I think what's the nicest is that when these patients come in, they're very high risk patients. And so, particularly with the mitral patients, I think we have really lively discussions about what's best for those patients and, considering devices, open surgery, and the nicest thing is that our opinions aren't always in concordance. We often disagree on what's best for these patients, but I think the best aspect of the heart team is that we can talk about it and then give the patient the option of which way they want to go with their care.
So Dr. Mack, I know that the heart team approach was initially sort of adopted during the partner trials, or at least started from there. Could you provide us with some historical context of what made the team sort of decide on it, and sort of how some of the challenges you guys faced initially as you guys adopted towards the heart team approach?
Sure, absolutely. And I get asked when I get asked questions like this, it reminds me of what stage of my career I'm at. I used to be an expert in innovation. Now I'm an expert in history. So it's sobering to a degree, but I'm just kidding. So the heart team actually predated the structural heart trials in valvular heart disease. It all started with the Syntax trial, which was CABG versus PCI. And Isaac is absolutely correct. This was all a product of the cardiology, cardiac surgery wars about CABG versus PCI. So there was a trial that was put together called the Syntax trial, which took patients with left main and 3-vessel disease and randomized them to CABG or PCI. What that did was it forced us to have to work together, us being cardiac surgeons and interventional cardiologists, because you had to both look together and say, yes, this patient is a good CABG candidate, and yes, this patient is a good candidate for PCI. It highlighted some of the early issues with getting a heart team together, and that's the logistics of how you get everybody at the same place at the same time. And as as Isaac and Sarah have said, our heart team is real. It's not virtual and it's not a checkbox, but you have to work at it to be able to keep it that way and make it work. I mean, everybody has to be inconvenienced, so that the patient is at the center of it, and shared decision making and heart team approach is made. At any rate, I used to have to scrub out a surgery and go over the cath lab and look at a patient on the table and look at their cath films and said, yes, this is a CABG candidate. And similarly, the interventional cardiologist would come to the OR and interrupt me in the middle of an operation. But that's what drove us together. Is this having to work together to decide whether patients were candidates to enroll in this trial. And pretty soon what we found is we would always say, yes, the patient could be treated by both approaches. And then we'd say, but boy, I sure hope it gets randomized to the other approach. I don't want to do a CABG on this patient because it's got such horrible distal vessels. And then the cardiologist would pretty soon say, what was I thinking when I said I could do this and put 8 stents in it? So it all served to calibrate realistic expectations of the team members. But then it segued on to the partner trial. And I, to this day, don't know who named the partner trial. I think it was somebody within Edwards. But it was prescient that name was put together for these trials, because it did kind of say it all in terms of working together. And from there, I think Columbia and Baylor are virtually the same. We've worked together, on these trials for 15 years now. At 16 years, 2007 is when we started all this. And we're virtually mirror images of each other of how we do things.
We're speaking about the partner trials with all of the evolution of what type of patients can have TAVRs. How has the role of the multidisciplinary heart team evolved?
One is we see all patients together, and right now as TAVRs evolved, the lines are pretty well demarcated. I mean, an 80-year-old that's got any degree of comorbidities, is going to be TAVR, and similarly, somebody in their 50s is going to be a SAVR. I think the biggest discussions that happen now are patients that are under 65 that want TAVR. And that age is creeping down, and it's patient preference. And of course, you have to, what the patient wants is priority. But where you think it's the wrong decision, maybe it's a bulky, eccentrically calcified aortic valve, or there's a dilated ascending aorta with it. And the patient really wants a TAVR, and the whole heart team knows that surgery is the right answer, or feels strongly surgery is the right answer. That's the crux of the TAVR discussions right now, in my experience. I don't know what Sarah and Isaac think.
I think the patients that are young that are coming in demanding TAVR are the toughest patients, particularly now with all the discussion of Ross versus, root enlargement. I mean, we have patients that we look at each other in our conference and we say, are we willing to give this 50-year-old bicuspid with an ascending of 5.2 centimeters? Are we willing to give them a TAVR? And we all look at each other and we say no, And so I think I worry about these patients in the community, because the patients that are really demanding these operations and wanting these operations are going somewhere else and getting TAVRs because they don't want open surgery. And those are the patients that I worry about that haven't been, educated the most about durability and what comes next. And so, I think in the academic environment, it's easy for all of us to say we still have heart teams and our heart teams are really valuable for our patients and our institutions. But I do worry about the future of some of the smaller community heart teams and the application of who they're going to offer TAVR versus SAVR with the low risk.
Yeah, these are all great points. I think one of the things to remember is that structural heart has just truly become commoditized at this point, right? This is something that you can go to the corner store and get everywhere and probably do a pretty good job of. I think the reality is that TAVR has not become so challenging, and you can get good results from average level and even lower volume operators. It used to be that there were these big discrepancies between mitral valve repair or a dissection repair or something like that. And I think those differences have really become nominal. You really have to find deep metrics to figure out if there's a large quality difference between these programs. And there are, but they're not probably as striking as we think. And so we do have this free market economy with medicine at this point, especially in the United States, where patients have their autonomy based on their own financial freedoms to make those decisions if it's offered. And the regulatory pathway that we have has offered it. And so this is the situation in the world that we live in. We can't go back and reverse whatever approval has been provided by the FDA, independent of whatever inclusion exclusion trials. This is what's out there, and this is there. In some ways, it's increased access of care. I'm sure there are a lot of people that are being treated now that were never treated before. And the implication of surgeons only doing, AVRs and not having their AVR patients being seen by a structural heart team is one of the thorny questions that always comes up. Should all the AVRs be seen by TAVR teams? What do you do with TAVRs that, aortic stenosis patients that aren't close to an aortic valve surgical center, but are close to a TAVR center? So there are a lot of inequalities that we have to face, in medicine. And in some ways, access to care has been improved by these kind of minimally invasive techniques. There's no question that, on the other hand, this concept of shared decision making is really thorny, where patients, because you have this ability to go from place to place and pick and choose in a free market kind of world, they can go, and it's medically, provided under whatever laws and allowances that we have. And patients are, trying to make those decisions. We have to help guide them. But I think to some extent the cat is out of the bag, and our line at our institution is probably a little more flexible than others. We say, look, is this medically safe? Are we going to hurt someone by doing this? And it's not medically safe or unsafe based on kind of a 10-year or beyond outcome. It's really the short-term outcomes that we're trying to get through. We don't want to hurt someone in the short term. The implications of long-term consequences, those are things that if we feel that we've educated someone and they're educatable, then we will go ahead. And so if a 55-year-old, absolutely says, I want to have TAVR, they're a bicuspid and they have terrible anatomy, we'll say no, right? That's medically unsafe. We will hurt you. But if they have great anatomy for a TAVR and they're 55-year-old and they have what we think are valid reasons for going forward, and we think they're, autonomously valid, then maybe that's okay. I'm not saying that that's right or wrong, but we don't necessarily limit care or access to care based on those kind of decisions, if patients want.
And so, at your respective institutions right now, how do you go about getting patients evaluated and having a team approach to educate not only the other partners in your team, but also to your patients to let them know what the best treatment plan is?
I mean, again, I'll answer that. So we get all of the data that we need to, whether it's the angiographic data, the anatomic data from CTs. We all sit as a group and review everything, and we try to come to a consensus. There's unfortunately no one formula to make a decision on any of these things. And as Sarah very correctly alludes to, that we sometimes argue. Maybe I push back and say, well, this person has a very small valve and they should never get this, and they should get this. And so we'll argue about that back and forth. Ultimately, again, patients have the right for decision for their own bodies, and they will make their own decisions. And so we, again, offer guidance for those decisions, and we offer medical therapies that we think are reasonable to offer. and ultimately the patients decide.
Yeah, we have a multidisciplinary clinic separated now for aortic and mitral, and we have one cardiologist and one surgeon at each clinic. We rotate clinics along with our coordinators and see patients together. I should add that I think the liveliest discussions these days come for valve-in-valve patients, particularly because patients are referred in for valve-in-valve from outside providers, and they don't always realize all the technical implications of valve to coronary heights and durability and, putting valve-in-valve in a 21 millimeter, mosaic or trifecta. And I think the liveliest discussions for our team right now come from the valve-in-valve patients. And I'd be interested to hear from Dr. Mack and Dr. George kind of how they, deal with a 40-year-old valve-in-valve consult that comes in with short coronary heights and, what the recommendations are.
Well, you're absolutely right. I mean, that is a patient gets sent in expecting to get a valve in valve, and they've got a 19 or 21 surgical valve in, and clearly the coronaries are going to be obstructed, and trying to talk that patient who comes in thinking they're going to get a valve in valve into a redo SAVR, especially if they just had the SAVR done, 4 years ago with a trifecta valve, is a major uphill slog. But you do the best you can from that standpoint. Now there's multiple ways of treating less than optimal patients, from fracking to basilica type procedures to be able to accommodate less than optimal patients, but still those are difficult patients to deal with. We do the same thing as Isaac does, is that we review when patients are seen, their whole workup is done. We have separate aortic and mitral clinics like you do, Sarah. It's actually mitral tricuspid, our mitral tricuspid clinic. We see about 13 to 15 patients in an afternoon in each of those clinics, and they've got a full workup done in the morning before we actually see them. So we have all the information at hand, and we discuss all the patients together before going into the room to see them. And then, and that includes surgeon, structural interventionalist, imager, mid-level providers, research coordinators. And first we decide, are they candidates for any trials? That's our first, level of decision making. And then we go in the room and talk to the patient together. And what you find that does is it keeps everybody a little more honest. You don't oversell what you do as a surgeon or as a cardiologist. And what you also find is the patient has absolutely no clue as to who the surgeon and who the cardiologist is. And it shouldn't matter, and it really doesn't in that environment. So that's part of the very positive culture that's created by all this. And as both Sarah and Isaac have said, TAVR has become commoditized and less contentious, and the decisions are more straightforward. When you get to the mitral and tricuspid, and then you even go into thoracic, aortic, and HOCM and things like that, that's where the decision making from the early days of TAVR now goes forward into those areas.
So the heart team on one hand has really helped streamline at least decision making, prioritize patients who are more complex. People have published data to show that it actually has increased volumes at other centers because you're seeing more patients as a group and appropriately referring them. But you guys also mentioned that your heart team involves physical meetings. You guys physically go, once a week, twice a week. So how does the individuals are reimbursed in that context? Like how do you get reimbursement for your time?
I think the cardiologists, surgeons, mid-levels, everybody's on different compensation models, but we we're salaried university employees here in my space. So, I mean, we don't get additional compensation at our facility that I know of.
Yeah, I agree. I think everyone's a little bit different. If you're asking how you manage the time, the time commitment for structural heart is that you see patients, you'll have to interpret data, and then you'll have to do procedures and then take care of patients afterwards. And different people do different parts of that. You get one bill, you bill one bill, the hospital gets a certain bill, and the physicians get a certain bill. The two physicians that get the largest bills, and they're not even that big, let me just tell you, are the surgeons and the cardiologists for the procedure. The imager gets this minute amount of, like you could go buy coffee with how much they actually like get paid to do their work. It's absurd. And then everyone else doesn't get any money. They just get a large part of the pie on a global scale from the DRG that comes in that supports the hospital and then gets funneled back to whatever valve center. So we don't get compensated for that time. We put in bills, the hospital bills for the preoperative clinic visit. And actually for post-op, you can also bill both on the surgical and cardiology side for the post-op visit. It's usually 1 or 2 visits as an inpatient. So those are the things that bill in addition to the testing that's done. Outside of that, there's no billing. There's no inherent value associated with the time that you see a patient in clinic per se, other than the bill that you put in the same way that it's no different than if you see a surgical patient in pre-op.
Yeah, and I would just, second both of those. When you see a patient for evaluation, only one care provider can bill for that. And those RVUs, we usually let go to the cardiologist. The surgeon works for free from that standpoint. But the way we encourage all our surgeons to go to clinic is this is the major referral source you have for surgical cases. So you want to be there, even though you aren't being compensated for it. The second part is that we do have directorships that in structural heart and over the clinics that helps subsidize the salary for work that doesn't generate RVUs. And then the third and for procedures, the reimbursement is still the way CMS set it up originally. And that's you can bill 125%. And it's split 2 ways. So 62.5 goes to a surgeon and the cardiologist for each of those procedures. But the ones that are really left high and dry that are crucial are the structural imaging folks. And especially when you need an interventional imager in a procedure like you do, now anesthesiologists are good enough for most TAVRs, but a lot of the sophisticated imaging, you need a dedicated imager and they get paid nothing. So we actually have our hospitals subsidize the imagers to be able to keep them around, keep them happy, and keep them working. And we subsidize them to a significant amount because they are so critical to this.
So one of the things along those lines, when you say it about the DRGs, I know that in 2017 or 18, Medicare changed their national coverage determination to decrease volume requirements for like TAVR. But there was also discussions about either potentially getting rid of the heart team or keeping the heart team. But then it sustained throughout. Do you feel like this would be something that would be continue to happen, even though I don't know how this landscape changes as far as reimbursements?
One is CMS loves the heart team. They think, they feel, and probably appropriately so, that it helps keep healthcare somewhat controlled. So they are very positive on it. I think the there has been a push by some to have an NCD reopened. And one of the issues is going to be changing the volumes, changing the need for a heart team, et cetera. It's not going to happen. CMS is not going to reopen the NCD, and the heart team's not going to go away from TAVR.
How do you expect training to best incorporate residents into the heart team and learn these endovascular skills?
It's a great question. Recently opened American Board of Thoracic Surgery cardiac track is now requiring 20 TAVRs. I think it's 5 transseptal procedures. So for residents and fellows now on the cardiac tracks, they definitely need to have more dedicated time in the structural rooms to get their numbers. And that's a big major shift in the last 6 months in our training. So I think, our residents rotate through vascular. The integrated residents have several months of cath lab. They have structural months. And I think you'll probably see that expanding at programs around the country, particularly for residents on the cardiac tracks.
This is such a tough question. This is such a loaded question that I feel like I've dealt with for 10 years. Um, this is not easy, and this is hard, and I've had varying viewpoints on how to train residents. We have a lot of residents that want to operate, and as someone mentioned, if there's a cabbage or a valve or an aortic case, they're going to go do that. And so we're a busy program, and so very commonly we won't have residents in our transcatheter valve rooms. Whether it's TAVR, clips, tricuspids, whatever it may be, it's all our cardiology structural fellows. And, they're very well trained. They're all functionally attendings. They've all done interventional years. And it's always been a little hard for the surgical residents to get really integrated into the training aspect and the cases. And so they've had such a great job market. They come out and make $1 million, in their first year. And so for them, they're going to come out and they want to do cases and do a lot and be busy, and they want to operate. They're surgeons, they want to operate, and they haven't been as interested in TAVR. So how do you get someone who's maybe not so interested? So you can provide all the tools, but ultimately people have to kind of want to drink the water, right? And if they don't drink the water, they don't drink the water, and you can't really force them. We have rotations, and we try to get people involved, and we try to get people to do stuff. And we've had people that really buy in and do a lot, and they get a great experience out of it. And then we have some people that just are not interested. And I don't get mad. I used to think, oh, everyone has to know TAVR. Everyone has to do this, this, and this, and this. And I've totally changed my mind. Not everyone has to be able to cannulate coronaries or do PCI or do complex stuff. I think every surgeon and every heart team is going to be different, and everyone's going to have a role that they fulfill. And it took me a long time to kind of figure that out. And every resident's going to have to figure out exactly how deep and how interested they want to be in the structural heart. I would like to think that TAVR, because now it's so prevalent, has to be part of our knowledge base for a cardiac surgeon, an adult cardiac surgeon. But I think but that may be up for debate. And as long as they can fulfill their role in a valve team to make themselves valuable, that's probably good enough.
What I can add to it is, so I am currently the vice chair of the American Board of Thoracic Surgery, and will be the chair next year. And there's probably nothing we struggle more with than this issue. And it's impossible to get it right, and we know we haven't got it right. And it's dynamic and constantly evolving. As Sarah said, we did change the requirements about 6 months ago, and have a purely cardiac track right now. What we do within, I originally thought years ago that, having every program have an Isaac George in it was the ideal solution to how structural heart disease could be treated. But Isaac is a unicorn to a degree, and there's some other unicorns out there: Gaurav Alawati, Rob Smith, etc., Yoshi Kaneko. But it's hard to scale that beyond individuals. And so what we do in our program, and other programs do also, is we have structural heart fellows. And every year we train one cardiologist and one surgeon dedicated to structural heart that after they complete their residency. But what that further does is it dilutes the experience for the cardiac surgery residents in training. And as Isaac says, some of them don't care and aren't interested, and they're doing the minimal to satisfy the board requirements so that they can say, they've scrubbed on 20 TAVRs. But they don't have wire skills. They don't want to get wire skills. And then the whole team doesn't want to teach them because of their attitude. So it is very, very difficult, and will continue to evolve based upon what the current experience of this current paradigm is. And as the structural heart field continues to grow with mitral, tricuspid, and other surgery and interventions.
I would say too, just for the residents on the call, having spent 10 years in private practice in my career, I think if you're really desiring to do a more community or smaller town private practice program, I think all of those programs are opening TAVR programs these days. And so it really suits you to get your experience in your training instead of, you're not going to be the one doing a 1 year extra structural fellowship if your goal is to be, a community CT surgeon. And so I think to keep that in mind, it's a good idea for you to try to get as much wire experience and structural experience as you can, because that's a lot of the future of our specialty.
And with the discussions that we've had, it's very evident that a multidisciplinary approach is very beneficial for our patients. But are there any disease scenarios that you think wouldn't benefit from a multidisciplinary approach?
So we've continued to expand the original concept. So we, like Sarah, have separate aortic clinics and separate mitral and tricuspid clinics. We also have a high-risk coronary revascularization service inpatient, so that anybody that has an STS risk greater than 5 or an ejection fraction of less than 30% that's planning on surgery has to be seen by the multidisciplinary team. Similarly, any high-risk PCI, CTOs, or cardiogenic shock needs to be seen by the multidisciplinary coronary team. We have a thoracic aortic clinic that we do cardiac surgeons and vascular surgeons together. We have a multidisciplinary atrial fibrillation clinic that anybody that's a candidate for surgical ablation or has had surgical ablation or has postoperative atrial fibrillation is seen in that multidisciplinary clinic. And then the latest is a cardiomyopathy clinic that's focused on HOCM and restrictive cardiomyopathies like sarcoid and amyloid. And that's staffed multidisciplinary. So it is a concept that we very much have embraced and have scaled to other diseases.
I think that's great. I'd also add, we recently, about a year ago, started a multidisciplinary endocarditis team. And it's really great to have the social workers and the addiction folks on there, and really helps with patient follow-up. So I mean, to me, I think the more collaborators, the better. It expands all of our knowledge, and it really helps with patient care and follow-up.
So that is a great thought, and we haven't done that yet, but we're considering it, especially now that you can use some of the pulmonary embolus extraction devices for tricuspid endocarditis. it is going to be emerging multidisciplinary team.
One other thing that I'll add, which took me some time to kind of understand and figure out, and this was a lot of structural heart, was kind of watching. I watched a lot. Especially here when we were first starting out, big sheets, and you have all these big names in the room, and so you don't do a lot. And there are still procedures that are specialty procedures, and this is kind of true in life where you don't get to do much and there's only so many cases, there's a small number of cases. Maybe that's true of your edge to edge experience or new devices or first in man's or whatever it may be, but there's still a huge amount of value in watching. And structural heart is not like you're not doing like, I would say brain surgery, but I don't know if that's the right, I don't know if that's the right call either, but maybe it's mitral valve repair, or maybe a David, or maybe a total arch, or something extraordinarily complex and very complicated from a technical standpoint. These are complex and technically difficult in a different way. And I think the subtleties that you pick up just by watching are underappreciated in structural heart. So I think you have to go into the field, if you want to go into the field, understanding that you're going to watch a lot. And you have to start integrating all these feeds of information, whether it's fluoro, echo, watching people do small movements. And then you'll find that when you watched 100 or 500 of these cases, you'll come in and you'll be able to do these very easily. But there are a lot of cases that are maybe billed or kind of set up so that one operator does a lot of it. And if you're not that operator, you may be out of luck and you may have to move to another institution to get that experience. But that doesn't mean that you can't still learn from the procedure.
Are there any challenges that you foresee as far as your multidisciplinary team approach so far? I know everyone's expanding, but do you foresee some challenges in the near future or long term from these approaches?
I mean, I'll just mention, and I'll let Sarah and Mike, comment. And that's that everyone wants to do these small specialty things, even if they've never heard of it. They all want to be the operators, and I think managing everyone's expectations in the group who all want to do the same thing. No one wants to do TAVR. Everyone wants to do edge to edge CMVR and TTVR, and so that's the challenge.
We always worry about retention of our team members, right? And so I think there's always a lot of movement in academic surgery. And if you lose team member A to a different institution, then your team's really going to change. And so, we're always trying to stress to our administrators how important our team is. And that's, I think, a big future threat.
I'd say our biggest tension is the logistics you continuously have to work to make it work. Um, eh, you know, uh, an operation runs over and you aren't making it to clinic on time. Or there's a STEMI in the emergency room and the interventionalist is on call and can't come to clinic. And who else can cover? I mean, there's always the easy default route is to just let one specialty or the other kind of see it based upon who's busy or who's not busy. But maintaining that culture is critical and you have to work at it. And everybody has to be inconvenienced a little bit to make it work. But the logistics of being able to get everybody there and there on time is the biggest tension.
So to end off with our last question too, for disciplines that are now incorporating the heart team approach into it, what is your biggest piece of advice that you can give these subspecialties in moving forward?
In my career, I've just really learned to love the multidisciplinary approach because I learned so much. And it's not always apparent, during valve clinic or during a procedure what you learn. But I think what you learn between structural and open surgery in terms of anatomy and different approaches and different ways of thinking is just, it's so instrumental to open surgery. And so I would say, really listen to your colleagues and trust everybody's opinion on the team. Because, I'll sit in a big complex third re-op mitral case trying to figure out what to do to this valve. And, I'll think of something I learned in a MitraClip procedure and kind of apply it to that case. And so I don't know. I think that the multidisciplinary approach is definitely here to stay in cardiac surgery. And as we subspecialize and subspecialize, there's just a lot of learning to be done from all of our colleagues.
I think the group approach is wonderful. You learn from your colleagues, as Sarah mentioned. You become friends, and I think the best way to be part of a team is to really be friends. It's hard to be a good team if you're not friends. I think we, as a group here, we have a number of people that are kind of all similar interests, ages and you know whatever it may be. So we all get along. We all do social things together, and we're all just very good friends. And so it's very easy to disagree and not be upset with people in that sense. If you're always trying to create conflict and you're not friends with people, then it becomes just a challenging work scenario. So I think it's been really good for us because we're all friends, and we create a team based on that dynamic because we really want our team to be a team. And it's not based on our professional qualities or whatever, it's based on those personal qualities, right? It's always, it's not, you can't put like, all the superstars in a room and expect them to work. You want the right team. And I think that's very much true of this as well. And then, I think you will do things differently. In surgery, you get really, really good by doing things over and over again and perfecting it. And I think structural is actually different. It changes the way you do things because you're thinking, how can I do this better? Not can I just move my hands better or do this same thing over and over better. You think, well, how do I not do this, but do something else that's better? And you always keep thinking that, even when you go back to your, let's say, AVRs or mitrals or aortic cases, you think, gosh, why am I doing it this way? And why can't they develop something to do something else, right? So I don't have to close the chest, right? Or whatever it may
Mm.
be. But I think you think of different things in a different way.
What I would add to this is, we all adhere to the scientific method and make decisions based upon evidence. We're an evidence-based specialty. And the heart team, it's hard to generate evidence to demonstrate clearly that there's better patient care because of it. I mean, it's kind of like motherhood and apple pie. Who can be against the heart team? You know, it sounds good. It's kumbaya. Everybody's, loves working together, but does it really translate into better patient care? And try to design the clinical trial that will generate the evidence to say that heart team trial is better. It's impossible to do. Um, Probably the closest that you can come is that Sami Elmaria, who was at MGH and now is at UCSF, and Karen Sapolka, who's at MGH, did a randomized trial of a shared decision-making tool. Patients came to clinic and got it or didn't. And they demonstrated that patient satisfaction from the clinic experience was much better by this heart team shared decision-making approach. But other than patient satisfaction, it's hard to demonstrate that that there is evidence that a heart team does better care. Now, they also have gone on now and just last month have been funded a huge PCORI grant, I think $7 million, to be able to try to demonstrate that the heart team approach is better, scaling off this initial trial that they did at MGH. So hopefully some evidence will come that this truly is better patient care, but it's everybody feels like it's the right thing, but being able to point to a p-value that says patient care is better this way, it's pretty hard.
So I just want to thank you, all the panelists, for sharing their time and their wisdom with us tonight. This is definitely the future of treating CV disease, and will be interesting to see the difference of specialties incorporating this approach.